Surprise! It's impressive. Why do you sit all the way over there? In a different capacity today.
He's in charge.
Oh.
He's still in charge. Whenever you are ready.
For the first. Yeah.
Are we streaming?
We are streaming. This is, the presentation hasn't made it to our email yet, so that's why you're seeing my Gmail up here.
I sent you the PDF version of it.
Yeah, yes, hasn't arrived yet.
Yeah, and then he is on the,
Oh, there it is. Okay, so we're ready. Yeah, but there I want to introduce the meeting first.
Good evening, everyone. We're about to start the first presentation. And hi to everyone that might unfortunately, I'm not sure if you can still see me, but I know you.
Can you talk a little bit louder, please?
Oh, okay. Hi, everyone. Thank you for joining Human Services in-person, virtual, hybrid, our first committee meeting. So I'm excited to have you join. For everyone that is in person and virtual, thank you. Our first presentation will be from Public Health Solutions, and I'm not going to give their presentation because I am familiar with the organization as I have worked for them. But Public Health Solution is New York City's largest public health nonprofit, been serving the city and state for over 65 years. And I think it would be great for us to know about one of their main projects, OU NYC, their social care network, especially in the midst of all of the federal cuts and the government shutdown, which is going to start affecting people very soon on Saturday. Public Health Solutions has a program that specifically Medicaid members who are eligible can benefit from now. So I wanted the board to hear a little bit more about this program, and once you do ask questions, then be able to take it back into your communities. And if you are a Medicaid member, you can get access to this. So I'll pass it off to Public Health Solutions.
Thank you, Jerome.
Talk to the front, yeah. And you tell me when you want to, change slides.
And you might have to talk a lot. I guess the speed is back.
Yeah, these are the microphones. They're just not.
Oh, hello.
Okay.
I'll stay. You said.
Big voices.
Good afternoon, everyone.
Good afternoon. Good evening.
It's Monday.
Well, thank you, Jerome, for that amazing introduction. And yes, we are from Public Health Solutions, particularly representing OU NYC, the Social Care Network. We're getting into exactly what the Social Care Network means. Next slide. Let's do a little bit of a welcoming introduction. So this is our lovely Brooklyn community engagement team. So we have myself, Mary Chambers. I operate as a community engagement manager for Brooklyn for our OU NYC Social Care Network project.
And I'm Sam Robert. I serve as the senior communications specialist.
And then we have two other community engagement specialists, but they also work quantity.
And so just a small point about our team. Across the four of us, we have language competency that William very deliberately picked up this team so that we represent on all four of the largest language speaking populations in job. So that's English, Mandarin Chinese, Spanish, and then Haitian Creole as well.
No, we're doing yet.
Not yet.
We have enough space on our team.
So now I follow you.
just a little bit about public health solutions. So as you all know, Public Health Solutions is the largest public health nonprofit in New York City. And for over 65 years, we have improved health for multiple New Yorkers and their families that provide direct services to communities in need by supporting over 200 community-based organizations annually through our contractual management services. When we speak about contracting and management, we deliver robust fiscal and administrative support for community-based organizations through state and also city Department of Health. We also have community reps, we work directly with community, so working directly with individuals and families to improve health outcomes. We have multiple programs and solutions in place there. So our program, our maternal child health department, and then also our WIC centers that and then after we have OUNYC Social Care Network, and like the Social Care Network, I think that we should
That's correct.
is
No, go ahead, go ahead.
oh,
So we're listening.
the New York State Department of Health just amended to the 1950 waiver that basically said that we do not only want to focus on physical health and also the mental health, but we also want to focus on social health, right? And trying to more comprehensive view of health, right? And with that, we have to also have a focus on social health. So social health are the things that affect our well-being and social, right? So housing, nutrition, access to viable transportation, what do your relationships look like? Is there any kind of violence or mistreatment in your relationships? Or any relationships, romantic relationships? And also, do you need support with educational attainment or also job placement? So we have a 12-question screen that assesses all of these things. And after once Medicaid members are assessed within these different realms of their social health, if there are any needs that come up, that they're connected to an organization in our network that can render those needs to come to you those needs for. And this is all with the goal of improving people's health in a person-first center type of way, and a little more comprehensive. We're not only focused on physical health, we're also focused on mental and social health as well. So, as I just said, a part of making health a reality is focusing on health in a more comprehensive way, right? So not only physical and mental health, but also our social. And through the legacy Medicaid labor, there's a focus on food and nutrition, housing, transportation, and navigating Medicaid members throughout the process of getting access to these services and resources that they may be in need of. Understanding that every year people die or they get sick because they do not have access to good food and nutrition, housing, and also viable transportation, or the right structure put in place for people to help to navigate these resources and services. So what is the social care network under the New York State Medicaid rate? So we operate as an organized technology-enabled network of community-based organizations that address the unmet health-related social needs of Medicaid members. So again, a lot of Medicaid members, just people in general, have social needs, right? And after, if these social needs are unmet, it can negatively impact their health outcomes. So what we're trying to do is meet people's social needs, right? So that they can have a good impact on their health, and then we can improve health outcomes in that way. And the first step in doing this is first screening Medicaid members to understand what their needs are. After Medicaid members screened, they're then navigated to a community-based organization within our network that can render that need to them, whether it be in food and nutrition, transportation, or housing, or a combination of these needs. After that, we are now tracking and reporting the resolution of these unmet needs. So the biggest thing is that for people who are working over here at Ultimate Public Health, we know that a lot of times when we give a referral for somebody, it can fall to be a case of referrals, right? And after somebody that got screened for something, they actually don't get hooked up with, they don't get the help that they need. So with this system, and especially at Public Health Solutions, we want to put New Yorkers, especially with Manhattan, Brooklyn, and Queens, where we are the lead entity in the social care network. We want to put our residents at the center of their care and ensure that once the Medicaid member gets screened, that they are navigated to the appropriate community-based organizations that can meet their needs. And then after that, those needs are then met, which means that the organization providing that Medicaid member with whatever their unmet needs are. And we're tracking all of that in a system called Unitas. to ensure that Medicaid members are not only getting the service and resources that they need, but they're also engaging with them well. And the theory is that when basic needs are met, people engage in preventive health care, they better manage their chronic conditions, and are less likely to require emergency care or hospitalization, therefore driving down healthcare costs over time for the individual and for society at large. And we want to prevent people from attaining chronic conditions, or if they have pre-existing conditions, trying to eliminate them from getting worse. So the goal of the social care network, as I said before, is that we are trying to create a comprehensive, coordinated, and integrated care system. Many times, a community-based organization is working in one silo, and then after a healthcare agency is working in another. We want to make sure it's an integrated system because we need to serve people best, right? One experience that we've learned throughout the social care network, just working here, is that when interacting with Medicaid members, a lot of Medicaid members see the system as one big system, right? So when they go to a healthcare agency or community-based organization to get something done, they see it as a system, right? And a system that usually is not helping them. So because Medicaid members, since people at large, see the system as this one big system, we then need to be comprehensive, coordinated, and integrated, right? Where all community-based organizations know each other and they can work together. And then also healthcare agencies are working along with the community-based organizations so that after we can then improve health outcomes. Also understanding that community-based organizations have many times a bigger stance and a bigger presence within the community than a healthcare agency might, right? Where people may feel a bit safer coming to a community-based organization. So we want to work with community-based organizations so to ensure that we are reaching people and that we're providing them with the best care possible. And as said before, we do not only want to focus on our mental health and also physical health, but also focus on social health as well. Strengthening the human service net, I'm strengthening that net so that we can then serve people as best as possible. So with the program, the state has recognized there's a growing recognition that fully achieving health for all requires a focus on health-related social needs. Addressing these social needs such as food insecurity, housing instability, lack of viable transportation. We understand that if we address that, it would improve health outcomes over time for each individual person. And New York State is funding the creation of coordinated infrastructure and set of processes to identify unmet health needs associated with Medicaid members and then to meet those needs. And then after the community-based organizations and also healthcare agencies that are within our network, they then get reimbursed for providing these needs to people. So whether that is screening a Medicaid member or navigating into a community-based organization that can render the need to that Medicaid member, there is reimbursement all throughout the process.
I do want to pause real quick. Does anyone know what the 1115 Medicaid waiver is? So basically, it's a waiver that states, all 50 states can apply for it to basically bill Medicaid for things outside of just healthcare, right? So with that waiver, basically makes the state eligible to use this funding to bill for food, nutrition, housing. That waiver is set to expire in March of 2027. So the waiver cannot be pulled, right, from the federal administration, but the waiver cannot be renewed, right? So there's going to be some advocacy when we start getting closer to that date and thinking about what happens and what's the sustainability of this program and like social care networks in 2027. But right now, if you're a Medicaid member, you can't have access to it. And what's also important about the structure of this program is that if you aren't eligible, and I know they're going to get into some of the eligible groups, you will still be navigated to an existing service, right? So he's going to get into some of our enhanced services that someone may be eligible for, right? But if you are, if you aren't eligible, you still get navigated to SNAP, you still get navigated to WIC, you still get navigated to existing services. And then the last piece, which he said at the bottom, is that in addition to ensuring that people are getting screened for these services, there's a community-based organization aspect. So we were giving over $152 million to contract, right, with community-based organizations throughout these 3 boroughs for them to provide this service, right? So we've been, since January 1, we've been going out in waves. Like I think it's called a rolling RFA or rolling RFP, where CBOs can still apply to join our network, but we're still taking applications for community-based organizations who either screen, provide housing services, provide food and nutrition services. So there's also that aspect, right? Is the community aspect, making sure that Medicaid members are getting screened, but also smaller community-based organizations are the focus of this, right? Not like large nonprofits that have a larger budget, even though they are part of the network. The focus has been to get smaller nonprofit entities in our network that has like the history of supporting people, the most vulnerable population.
Now, to Jerome's point as well, because it ends in March of 2027, because we don't know if it will be renewed, what we're trying to do is to prove that this works, right? That the creation of a social care network and, you know, coordinating care amongst healthcare agencies, community-based organizations, and serving Medicaid members, that theory that was on the screen a few minutes ago, that if we can meet people's needs, right? And that it would then lower the cost of healthcare over time. And that's why we were trying to make sure this is successful, that it can become a definite part of our public health. So we need the help of each and every single person. So even though we're getting to what the ecosystem looks like, and actually I'll leave that ecosystem. Next. So as Jerome was saying, the social care network is large just for New York State alone. Each county does have a different lead entity for the social care network. So for New York City, we have the largest social care network because we have Brooklyn, Manhattan, and Queens in our state, in our social care network. So Public Health Solutions serves as a lead entity. So what we're tasked to do is to create, to coordinate amongst healthcare agencies and community-based organizations to then have that be the network, and after that network is then serving the people. And after Public Health Solutions is a leading network in Brooklyn, Manhattan. So with our social care network, we have community-based organizations and also healthcare agencies that are contracted and partnered with us throughout Manhattan, Queens, and Brooklyn, all serving the Medicaid member populations. For the Bronx has Sonos healthcare providers, and then after Staten Island has what's called SIPS, or Staten Island Performing Provider System. And we call our social care network Whole You NYC, and we have some great money. So for Whole You NYC, the approach that we take to our work and as a whole organization, and particularly with the social care network, that we want to put New Yorkers at the center of our work. We want to create partnerships that coordinate care well, and we're building a coordinated network of community resources in New York City, and we incorporate a hands-on community process and ensure services are equity, access, and delivery. As I said earlier, we don't only want people to get services and resources put in front of people. We want to make sure they're engaging with those services and resources well. And that's why with the social care network, and we'll get into a little more detail later, it's an end-to-end process, meaning that once the person is screened, all the way to services being delivered, we're tracking that. And after we have a social care navigator as assigned to the person to ensure that if the person is getting meals, right, then after that person likes the meals that they're getting, right, it is culturally appropriate. If someone is engaging with the social care network navigator, that the engagement is culturally and linguistically appropriate, and then after their care is culturally responsive to that specific person and their family.
So I have a question. So in regards to reimbursement, you know, I understand, and we've spoken before about this. So hello, sorry for entering late. But in regards to reimbursement, like, how does that work? Is it after the work is completed for the CBOs? Like, are we assigning a specific caseworker on this to work on this project that you collect? Because you are technically collecting data from us, right? So I know that's in the agreement. I mean, I think that's where we stopped in terms of the agreement, because you're collecting data, but then there's no specific contract of like, this is how much money you're definitely going to receive to hire someone at the CBO. It's just you're collecting data in all the different departments. So in terms of the reimbursement, is it per client and how often in the month? I mean, community-based organizations are constantly waiting to be paid. So just throwing that out there now.
Yeah, and I can touch on, I think you were from a COPO council.
Yeah.
Yes,
Yeah.
exactly. So the reimbursement funding scheme is specifically per service. So we have the our social fee schedule, which is accessible online for anybody to see, but also that's one part of the application material that CBOs are able to access when they're applying to be part of the network. That fee schedule indicates the rate per individual service. So, for example, if an organization like Copa is providing, I think you guys do halal meals. Exactly. So when you're providing those services under the SCN, and what dictates it, because obviously CBOs are already providing their own services, but what makes it a SCN service, a whole new NYC service, is that you're providing that service to a Medicaid member through that platform that we were mentioning. And so, for example, in the case of a home delivered halal meal, that is reimbursed at a specific rate across the 3 boroughs. So, and that's outlined. So for our home deliveries, not too specific, but I know for sure for our pantry stockings, it's about $30 per box, right? So you're giving a box of pantry stockings to a Medicaid member, and Public Health Solutions is reimbursing the organization for that rate. And so that's going to be a set rate that is really transparent. So when executing these services and delivering them, especially the customers such as pantry stockings or home delivered meals, you can, as an organization, you can execute them in a way that is according to the fee schedule to make sure that it is reimbursable, that you cover the full cost. And so, so that's the reimbursement scheme. And William's going to speak a little bit more so towards the infrastructure grant, what we call the capacity building dollars that are accessible to CBOs as a contracted partner. So we want to make sure that not only will we give you the back end funding, but also that you have enough dollars prior to your execution, your execution of services, that you have the infrastructure to be able to offer these services in the first place. And we could definitely speak more to specifically talk about this as well.
Okay. Thank you.
Yeah, and that, just to add to what Sahil said, we gotta have 3 different rounds of how an organization does get reimbursed. So you have the screening, you have navigation, you also have service delivery. So with screening is like how much is screened that an organization would then ask a Medicaid member, which would be the first step in the process. And after Medicaid, and after the community-based organization screening, then after they get reimbursed for doing that screening, I believe it's $17.50. After I believe greater than 8 minutes of screening, greater than 8 minutes of screening that Medicaid member. The navigation piece is the eligibility assessment. So just like how we have a 12-question screen, the eligibility assessment does ask a few more questions, a little more of a comprehensive version of the screening, which does take a little bit longer. And after then the community-based organization is also reimbursed for doing that if they do choose to do that when they do sign up to be a part of the social care network. And then also what Sahil was mentioning is that service delivery. So even outside of food and nutrition, the housing services, the transportation services, if your organization does offer that, along with a few other care management services as well, like paper-based applications and things like that. All of those things are reimbursed. Now, the details of how an organization will be reimbursed and how much they will be reimbursed, and also the duration of time that they can be reimbursed, is all detailed within our very comprehensive fee schedule that comes from New York State.
And so besides the fee schedule and all this, great. But again, you're collecting the data. What's going on with the data and how are CBOs recognized in that process, or even after, right? Because now I think it's the bigger picture of like going back to the city state from additional funds. So how are CBOs recognized in that?
So to speak to the data, so the only information that Public Health Solutions is collecting on the CBOs in our behalf is going to be that 12-question screening, and those 12 questions all specifically are just to assess the needs. So out of the 12 questions are broken into 3 categories. So they ask about 3 questions in regards to your living situation. I was doing screenings earlier today. At a food pantry, what is your living situation? Do you have a steady place to live? Are you worried about losing the future? Within the past 12 months, have you had concern that your food will run out before you might spend more? Do you have in the past 12 months has a lack of reliable transportation kept you from medical appointments? So the data that we're collecting is exclusively to identify what a member's needs are. That's the only information that we're collecting from members and from community-based organizations as well. So I'm not sure if are you referring to the screening data and how that's used?
So even with the screening questions, you're collecting the data for it's a needs assessment you're technically doing, right? And so you're going to present it somewhere. It's going to go somewhere. But I think I'm just reluctant because constantly what happens is CBOs are just like in the notes section, right? Yes, there was 20 CBOs that we worked with, but like what is the recognition that the CBOs are having in terms of funding? Additional fundings maybe after the 2027 when it ends, and what you're going to be doing with this data. Again, like what's the long-term relationship with the CBOs in regards to this?
Yeah, that's a great question. So actually, the CBOs are actually the center of the work. So Public Health Solutions, we have a small team screeners and navigators. There's the 5 of us that we conduct screenings, but the bulk of, I think we're at about over 10,000 screenings in, is done by community-based organizations and healthcare providers as well. And so CBOs are at the forefront of our work. They're the main executors of our work. And so all of that revenue schemes is going to you all. And so to get to a little bit more specific, so we actually just rolled out an incentive program as well. And so that's the information that you'd be having access to as an executing partner, which Coco currently is. So we have an incentive program where we're trying to provide additional funding, as many dollars as possible, to community-based organizations. So specifically, let's just get into the nitty-gritty of the funding scheme. So internally, and when we communicate with our partners that are providing services, the reimbursement scheme, like I said, it's the $17.50 per every 8 minutes. So if a person is sitting down and engaging in a screening with a Medicaid member, that's reimbursable. So that's an additional revenue scheme that is accessible to the community-based organizations. And very oftentimes, CBOs will have, let's say, caseworkers that are already doing this similar type of work. And so by adding screening into their workflow, they now have an additional revenue scheme that wasn't accessible to them prior. And so that's only just for the reimbursable funds. But as mentioned, also the infrastructure grant, which I can speak to a little bit now. The infrastructure grant is completely upfront dollars that once you are a contracted partner and you completed the trainings, well, just one person has to complete all the trainings for the SEN services, you're able to access the infrastructure grant, and that is to build out all the services that you need to be able to execute SEN services. So that includes things such as hiring new employees. We offer about 6 part-time or 3 full-time employees, enough dollars to cover that. If you need to offer your services, one of our community-based organizations that serves Spanish-speaking population here in Brooklyn, they were able to build out a community kitchen within a new space to offer home delivery meals and things of that nature. So those are additional dollars. But the incentive program is to highlight and exonerate even more so the services that CBOs are delivering, where if you are meeting certain metrics, even outside of the reimbursement rate, we're getting a bonus extra dollars because of the work that you're doing. And just to provide additional incentive for our community-based organizations that are executing that work. So CBOs are very much at the center of it, and they are getting the dollars that are reimbursable and also kind of even additional padding for CBO to continue their STF services and whatever community-based services they're offering at large.
And we'll talk after. I actually work with them, but I know we have to keep moving, but we'll talk after this.
Sorry, yeah, go ahead. I
Yeah,
can take over.
Yeah.
But is that also just add one more point to that too. In speaking about data, when we do collect data on the community-based organization to see exactly what the screen numbers look like. So that after, let's say, if your organization we screen, let's say 500 people this month, right? And that is something that we continue to look at to see, oh, your organization is doing really well with screening, and you're also doing really well with navigation, and also doing really well with providing services to Medicaid members. And if you then say in your year 2 capacity building funds application that you need 3 extra people to build out your organization's capacity to do even more work, then after that's something that could be granted to you because you've done so well in the social care network, and after you're asking for capacity building funds to even do more work. And after that, so like if it does answer your question, we do collect that type of data where we have a database where we can see how each organization is doing. Then after we would then evaluate that for companies or CBOs capacity building. So we do have a very large ecosystem. We don't do this work by ourselves. So at the center of our work are Medicaid members, which are our largest and most important stakeholder group, the people that we serve. Around Medicaid members, we have Public Health Solutions that serves as the lead entity for the social care network in Brooklyn, Manhattan, Queens. We partner with community-based organizations and also healthcare providers and other health-related social needs service providers in order to screen, navigate, and provide services to Medicaid members. Within our larger ecosystem, we have formal and informal contracts with managed care organizations, local government, child and family supports, and also larger health systems and other partners. So for example, community-based organizations will be part of our ecosystem. Even though we don't have a formal contract with each community-based with each community board, we do work with the community boards in order to be connected to the community, make sure that our social care network is grounded in the communities that we're trying to serve. the UO would be an example of one of our other partners. And for SCN service delivery, so the first step is the first step each and every single Medicaid member screen. So a member is comprehensively screened for their health-related social needs using the Accountable Health Community's standardized screening tool. For many of you, you may know about the social determinants of health. So when we think about social determinants of health, these are like the factors that are affecting health outcomes within the community, which are very broad. However, health-related social needs basically just narrows it down to the individual and what does life look like for this person at this moment in time. And as Sahil said, having this 12-question survey that's assessing food and nutrition, transportation, any kind of interpersonal bonds that someone is going through, if they need support with education or job opportunities, and transportation as well. If an unmet health-related social need is identified, the person then reaches out to the navigation piece. So in navigation, it's a little more of a comprehensive screening, a little bit longer. So a social care navigator, our organization, one of our partners, would then do that eligibility assessment with the Medicaid member to see exactly what they're eligible for. Are they eligible for these enhanced services in food and nutrition, transportation, and housing? Or are they only eligible to get local, state, and federal resources? And then after we see what they're eligible for, then we then move on to the next phase where those services will then be delivered to them. So particularly, this is more so for people who are eligible for the enhanced services. They would then get navigation organization within our network that can provide every service to them. And after if a person is not eligible for that enhanced service, they would still be navigated to relevant federal, state, and local programs that can still be there. And then the referral loop is closed after the person finishes getting their needs met. And this will take a very long time, right? So for example, if I am a pregnant person who needs medically tailored meals, I can get medically tailored meals for a whole year, right? Then after I get completed my medically tailored meals for a year, then the referral loop is closed because my services are complete. And if I want to continue getting services, I'll then have to redo the screening and then I have to go through the process again. So I have to see what my new needs are at this moment in time. And after hopefully get services if I have any unmet needs. So it's 3 steps: screen the Medicaid member, do a assessment with them to see what they're eligible for, then I have to provide the services to them that they are eligible. And after when we speak about the enhanced services that people are eligible for, I'll first start with housing. So home accessibility and safety modifications. We know that many people do need help getting around their homes, especially our elderly populations or populations that may not be as mobile. So we have home accessibility and safety modifications, home remediation services, asthma remediation, medical respite, rest and temporary housing. I'll touch on that a little bit more. So through the social care network, we like to see Medicaid waiver. If a Medicaid member has registered arrears up to 6 months, the social care network, if eligible, can pay those rental arrears on behalf of the person. So very important, especially knowing that New York City does have a housing crisis. We do have utility benefit assistance, pre-tenancy services, through transitional supports, tenancy sustained services, and also housing transition and navigation services. Helping people to find homes, helping people to rent, helping to make sure that a person's home is safe for them to live in, and also helping them to put on or to maintain their utilities. For nutrition, we have nutrition counseling, education, medically tailored or clinically appropriate home delivery meals, medically tailored or nutritionally appropriate prescriptions, fresh produce and non-fresh groceries, and also cooking supplies. And then after a lot of nutrition services are tailored for someone's they have any kind of condition. So for example, if someone does have diabetes, and after the food that they get would be appropriate for them. We also have transportation services. So this is transportation to non-medical services. So for example, if it is a Medicaid member is eligible to get their rent paid, right? And after they have to go to a community-based organization to have a conversation with the social care navigator at that organization, transportation could be provided to that Medicaid member just in case they don't have the means to get to that specific appointment. And then after we have, if you go back, and after we also have care management, so we navigate the Medicaid member throughout the process, and also providing enhanced care management to them. So if they have any applications that need to be paid for, all of that can be rendered to Medicaid. And after this, the eligibility for these enhanced services that we just aforementioned. So first, the Medicaid member has to demonstrate one or more unmet social needs. So on the 12 questions screen that Sejal was speaking about, answering yes, I do have a food need. Yes, it has been hard for me to get to to work or to medical appointments. And answering yes to those questions. Housing is unsafe. I am going to interpersonal violence. That would then send the person to the next part, where the person is enrolled in Medicaid managed care. And then from that, the person has to meet one or more criteria for the enhanced service populations, which are priority populations. So the person will have to either be a Medicaid utilizer, which is defined by the number of emergency department visits or inpatient stays in the hospital or clinic that a Medicaid member has. Knowing that a lot of Medicaid members may not have, or people in general may not have a primary care provider and maybe utilizing the emergency room as a room primary care. So you want to bring people who are Medicaid high utilizers extra services and resources, and also connect them to a primary care physician. Members enrolled in New York State designated health home, members with substance use disorder and or serious mental illness, members with intellectual and developmental disabilities, pregnant and postpartum people up to 1 year. Members who are up to 90 days post release from incarceration with a chronic health condition. We definitely want to have an emphasis on our justice impacted populations, and also high risk children. This means that someone under the age of 18 years old who has any unmet health related social needs.
And before you go into the next, I just want to do a quick time check, just out of respect for the other people who are presenting behind you. But this is so great that I hated to do that, but I just did it.
But we have stopped.
Well, wrap up.
I feel like 2 more minutes.
Okay, so next one. So we don't have to go through this screening, the eligibility assessment, and then after they get navigated to whatever they may be, whatever services they may be eligible for. So they either be enhanced services or state services. So every medical member that gets screened gets navigated to some kind of resource to help them with their health related social. We implore every Medicaid member to get screened, and please do connect with us so that we can, screen your population, and you can come onto any venue in any capacity to do screening the populations that you serve. Faith-based institutions, police organizations, any questions?
So, okay, so I'm coming at this, I would think local health, which is like, sort of medical community spread of the whole like Crown area. And one of the issues that I find, and you sort of started to touch on it with the needing a primary care provider, is that a lot of the people that I see don't understand how to use the system. They're eligible, they have the Medicaid, they can get the services, but they don't know how to actually go about that step by step. Pick one of our local providers as their primary care. If it's, okay, so you had your appointment and you told, oh, we'll see you in a year, but there's an issue. Instead of they're getting in touch with their primary care, they'll either show up in another primary care with a complaint, or they go to the emergency room. Might be a lot of emergency room and urgent care. They don't know what to do if they have a problem filling a prescription. For instance, it's not a covered item, and we don't know because there's so many variables, and so they don't know. They get back to the provider and say, "Hey, I couldn't get this covered. I couldn't get it. Can you find out why?" Or whatever. Because the will is that. So if they want to start short with things, I think that a lot of people in the community need somebody to help them understand how to navigate all of those pieces. They've got the eligibility, but there's then their gaps in how to actually best utilize it. I think that's something that you could do, or maybe we need to invent another department that works on that or something.
Yes, that's exactly what we do. So in that navigation piece, each Medicaid member is assigned a social care navigator. Understanding, to your point, that a lot of people, there's a lot of uncertainty, mistrust, distrust, and just it's just hard to a lot of times navigate the social and just the healthcare space. So we definitely have a social care navigator that would then help the person. So once the person gets screened, the social care navigator would then do the eligibility assessment with them. And after from that, would then, ask me certain questions and be sure that they get to the correct, the appropriate community-based organization that can render whatever it is that they have. And after they then continue to follow up with that Medicaid member to ensure that whatever services or resources they're eligible for, and they're engaging with, that they're continuing to engage with them, and they're engaging with them well. And after if a major life event does happen, or they have a new need, right, then have to redo the screening with them, redo that eligibility system with them, and have to connect them with that new need to meet that need that they need. So yeah, social care navigators were the person who all throughout the process. After they would then have a number for that social care navigator in order to call them to give them income properties.
There should just be teams of social workers in every ER, every senior center, every.
Any other questions?
The basic thing is reach out. So how you, or how individual reach to those benefits or those programs. How he or she thinks that individual know about these programs.
By coming to things like this, right? So that's what our community engagement team has to do. To inform people of all these services, all the resources. The one thing that we want to do is that we don't want to keep the power with ourselves, but we want to partially transition, right? Meaning that we want the people who are in the community to also educate the people who they have proximity to, and the people they also have ability to also educate them about exactly this, right? And then hopefully we might be into the space where we can have this conversation, maybe do presentations. We can inform everybody about, all the different factors of the social care network and things that they may be eligible for if they are. Yes.
CBO, healthcare.
CBOs, healthcare agencies, schools, community, all the different community venues, so barbershops and salons we go into. We try to, our philosophies meet people where they are and serve them there, right? Understand that's not just in going to the physical places, but also meeting people in their understanding as well. Meeting people and trying to be as culturally responsive as possible, linguistically, culturally, all the things. So yeah, our team does it all.
Sorry, do you have like a flyer, contact information?
Yeah, we have flyers on and after. You can also take my number. You can also my email just in case you want the book and community to come out to anything that you need to have. We can do the work of awareness, education, sensibility. All Medicaid numbers that you know to all these things. I'll get my card to you.
So thank you so much for our two representatives from Public Health Solutions for this great presentation on COVID-19 around our second presentation on COVID-19 and vaccination information, and we have representatives online from the New York City Department of Health and Mental Hygiene.
Hi, I'm sorry. It's kind of low. Did you mean Afia? Afia's turn?
Yeah, go ahead.
Oh, okay. I couldn't really hear. It's pretty low. Good evening, everyone. My name is Afia Mikulski. And I am the Brooklyn coordinator for the Office of External Affairs Community Affairs Unit at the New York City Department of Health. Today, I'm going to be speaking a little bit about access to COVID-19 vaccine as well as the flu vaccine. And I'm going to share my screen. Please just let me know if you're unable to see it. Okay, is everyone able to see my screen?
Yes, would you be able to put the presentation in presentation mode or to make it bigger on the screen for us?
Get in presentation mode.
Sorry, my bad.
All right,
Perfect. Thank you.
no problem. Okay, so as I mentioned today, we're going to speak a little bit about respiratory viruses and any updates regarding respiratory viruses. So what are respiratory viruses? Respiratory viruses are viruses such as the flu or COVID-19. Who is at increased risk for severe disease from respiratory infection? So older adults, so anyone usually over 65 plus, young children, especially babies, at a high risk of, getting a respiratory virus, pregnant people, Black, Indigenous people of color, and residents of long-term care facilities. And also to add, individuals that have weakened immune systems, they are at high risk of contracting a virus. So again, young children and older adults are more likely to be hospitalized with respiratory viruses. Infants are 11 times more likely compared to other children in groups 5 through 17-year-old to contract the virus, a respiratory virus. And again, adults over the age of 65 are 9 times more likely to contract a respiratory virus compared to individuals between the age groups of 18 to 64 years old. So today, COVID-19 hospitalization rates have increased each winter and summer in New York City every year. And of course, this can be attributed to, these are the times that usually New York City is very congested and packed. And that's how we kind of see like the uprise of these viruses throughout the city. So vaccines. Access to vaccines. So recommendation, updated COVID-19 vaccination is recommended for everyone 6 months and older. It's especially important for children 6 to 23 months, older adults 65 years old, 65 years and older, those at increased risk for severe COVID-19, those living with someone at increased risk for severe COVID-19, those with higher risk of exposure to COVID-19, and people living or working in a care facility or another congregate setting. So usually anywhere there's large groups of people gathering, you have a higher risk of, again, contracting COVID-19. So it's recommended that if you're consistently in large crowds to consider getting the COVID-19 vaccine and the flu vaccine. So here are some benefits of the flu vaccine. There are many reasons to get your annual flu vaccine. The flu vaccine is the best way to protect yourself against getting sick with the flu. Getting vaccinated reduces your risk of severe illness, hospitalization, and death if you do get the flu. My apologies. The flu vaccination helps protect pregnant people from flu during and after pregnancy and helps protect their infants from flu in their first few months of life. COVID-19 and flu vaccine recommendations. Again, as I previously mentioned, the age groups that are recommended to receive the vaccine yearly are 6 months and old, are individuals 6 months and older, and they should receive it every year. So every season, the virus looks different. So that's why we recommend that everyone stays up to date on these vaccinations. These vaccines protect against the currently circulating COVID-19 variants and flu strains, and should be given every fall. People should receive these vaccines if they have received COVID-19 or flu vaccines or have had COVID-19 or the flu before. So RSV vaccine is usually recommended for individuals that are 75 plus years. If you have high risk of getting RSV, it's recommended that you speak with your healthcare provider to see if it's recommended for yourself to receive the RSV vaccine. So get vaccinated. I wanted to show people where you actually can look up in your community, in your area, where you can receive the flu vaccine as well as the COVID-19 vaccine. So if you simply go on newyorkcity.gov/health/map, there's an interactive map that you can, so take you to this landing page. You scroll down and press vaccines. All right, and then you can, these are all the vaccines that you can search for throughout the city, COVID-19. And you have to press one vaccine at a time. It won't let you pick multiples, but you press COVID-19 vaccine. You can go to location. I'll type in any zip code. And then it'll narrow down. See, it comes down to 45 facilities. It'll narrow down it'll show you a map view as well as a list view of pharmacies in your area that are offering the vaccine. In regards to actual healthcare facilities, you can go to your physician's office and see if they offer the vaccine. If not, then a pharmacy will be the next best option to see if you are able to if you're able to get the vaccine there. Okay. And then also to add, the vaccines is covered by Medicare, New York State Medicaid, and other health insurance plans. And if you do not have any one of these, if you don't have Medicare or Medicaid, you can see if your private health insurance covers the vaccine. But mostly this is because this is like, preventative. This is a vaccine that's usually covered under everyone's insurance. And then the last link kind of also sends you to the site where you can look for clinics that are offering, DOH clinics that are offering the flu or COVID-19 vaccine. So frequently asked questions about vaccines. Why should I get an updated vaccine if I was already vaccinated last year? So both the COVID-19 and flu viruses, it keeps changing, as I mentioned before. And our immune system can lose memory of, the vaccine that we received in the previous year. Again, that's why every time we come around the fall time, we advocate and encourage individuals to get vaccinated. The updated vaccines for both viruses are specifically designed to protect against currently circulating variants or strains and strengthen your immune system. So if you get infected, you can better fight the virus. Currently, there is no updated RSV vaccine. And again, as I mentioned previously, you can speak to your healthcare provider if you are within that age range that I mentioned, if getting the RSV vaccine is right for you. Why should I get vaccinated if I might get sick with a respiratory virus anyway? So like all vaccines, those for respiratory viruses are not 100% effective at preventing infection. These vaccines work to reduce the risk of hospitalization and death, and also reduce symptoms if you do happen, to catch the virus. So COVID-19 vaccines also reduce the risk of developing long COVID. Again, get your vaccine. You can get your vaccines at the same time. It's actually recommended, right? It's safe to receive the vaccines all at the same times, and it ensures you have protection against multiple illnesses. So stop the spread. Ways to stop the spread of respiratory viruses. Again, get vaccinated. Seek treatment if you're sick or you have like the symptoms of either COVID-19 or flu. See a healthcare provider. Get tested. Also steps for cleaner air. So if you have like you can have an air purifier in your house that kind of traps those like pollutants or toxins that are in the air that may be flown around in your home. Hand and surface hygiene, so keeping your personal space clean and washing your hands, of course. And simply, if you're sick, stay home. Try to stay away from people for at least 24 hours once you initially get those symptoms that you're feeling like you're sick, to avoid the spread of any virus that you may have. So respiratory virus guidelines. Again, physical distancing. If you do have to go out in public, wear a mask in case you cough or sneeze, so that you don't, to prevent the spread of the virus that you might have. And again, as I mentioned, testing. So respiratory viruses are causing a lot of illness and can cause a lot of illnesses in your area. If you were recently exposed to a virus or sick or recovering, and you or people around you are a high risk for severe illness, these are strategies that you should take. So in summary, being up to date with vaccines remains the best tool to prevent severe illness, hospitalization, and death. Everyone 6 months and older should receive an annual flu vaccine and updated COVID-19 vaccine. Older adults and some pregnant people and young children should get RSV vaccine if they haven't received it before. Using prevention measures in combination is the best defense in regards to getting a respiratory virus. Again, these are some resources. I can share this presentation towards the end for anyone who is interested. And does anyone have any questions?
No, but this is Sean, and if you could share that deck, we'll post it on our website along with the recording of this committee meeting.
No problem.
Thank you.
One more time, questions? Any questions from anyone in the room? Thank you so much for presenting to us and sharing this information about respiratory viruses.
No problem.
So now we've come to other business in our meeting agenda. I believe we have Jack. Jack, are you
Hello.
able to?
Hello, good evening, everyone. Can you hear me okay?
Yes.
Great. First of all, I want to thank the district manager, Sean Campbell, and her staff for allowing me to speak with you. I'm going to be very brief. I know that you folks, you had a lot to cover today. And if I might add, I did get both of my vaccines, the flu vaccine and the COVID vaccine. My wife is a retired nurse, and she made sure that I got it. But what I'm here to speak with everyone tonight is the New York City. Our Medicare plan is traditional Medicare, and we've had that almost forever. When we came into city service, and I'm talking about police, firemen, teachers, sanitation workers, court officers, the nursing folks, there's about 250,000 retirees, New York City Public Service retirees. And one of the recruiting tools when we came to work for the city, we were told, you're not going to get rich on this job, but you'll have a decent pension and you'll have excellent health care. Now, when we came on the job, I came on over 40 years ago, there was no such thing as a Medicare Advantage plan. It was just always traditional Medicare. So we just were under the assumption and the promise that you're going to get traditional Medicare. But as time has gone on, a lot of different private companies are trying to get in on the act. And what they're doing is they're taking away the freedom of choice that we traditionally had. They're putting us, the city is trying to put us into a plan that's inferior to what we have now. The reason it's inferior is traditional Medicare, you can almost see any doctor in the United States. There's usually never a problem with denials. If there is a denial, it's usually taken care of very quickly. The companies, the Aetna Medicare Advantage plan, they're a for-profit business. They can make money by denying care, by making sure that whoever is seeking care is within their narrow network. And the appeals process is very cumbersome. Now, I did send a text because I wasn't sure if you would be able to hear me clearly. And it pretty much explains that a city councilman, Christopher Marte, he's from Manhattan, he's in district. He introduced some legislation to the city council, and it's called Intro 1096. And if that passes in city council, then it becomes a law. So it wouldn't matter who the mayor is. Mayor Adams was following Mayor de Blasio's lead, trying to get this Aetna Medicare passed. And we have fought it every step of the way. This group that I'm involved with, it's the New York City Organization of Public Service Retirees. We have won every court case, but the city kept appealing. Our most recent case, we actually had 2 bus loads go to Albany. I was in one of the buses, and we addressed the New York State Court of Appeals. I always thought the Supreme Court was the last stop, but apparently Court of Appeals is even above them, and they ruled unanimously against the retirees. So what that meant was that court was saying, yes, New York City can force you into this new plan. at that time, Mayor Adams said, I'm not going to put you in that plan anymore. So back then he was running for re-election. So part of the intro 1096 is once it's a law, it doesn't matter who the mayor is, we would have our promised Medicare. And as I mentioned, I'm a retired NYPD lieutenant. I was out there as the sanitation folks, the firemen, the teachers, people that work for the health services for New York City. I mean, the plumbers. We live in a very complex city. And as a little aside, I see you folks are coming here. You guys do a great job. You're volunteers. You're keeping the city going. All 59 community boards. People like you want to get home after a hard day of work. And that's why I'm going to keep my talk short. What we're asking for is each of the community boards, in this case, Brooklyn Community Board 14, if they would write a letter of support, and we can guide them as to what some of the other community boards have written if you want. We're hoping to get 59 letters that we would present to the speaker, Adrian Adams, who was the speaker at the city council, and show, listen, these are the grassroots people. These are people from the community that their community board is supporting us. Please pass Intro 1096. So I thank you, and I'm available to answer any questions you might have. And I do thank you again for allowing me the opportunity to speak with everybody.
Thank you. Does anyone have any questions? I'm going to keep it. On the other side of the.
I'm sorry, if somebody's asking me something, I can't hear the question.
That was Jack, it wasn't, it was a comment. So you're good. We can be in touch. Thank you for taking the time to lay it out tonight.
Thank you, everybody. I appreciate your time and get home safe.
Thank you so much. Have a good evening.
Thank you.
Does anyone else have any questions? Besides being members of the committee? Any suggestions of topics for future meetings? If not now, that comes to mind, please be in touch with us as we find opportunities.
Can you just go around and introduce ourselves and just give like the one liner about what we do? I guess one of the reasons why we wanted to convene the committee in person. To get to know each other a little bit.
And Jack, we can let you go because we're gonna turn to other business here. If you want to go ahead and sign out and go back to your evening. You can.
Thank you.
Sure. Yeah.
Should model.
Hi, everyone. My name is Gerald Gray. I know this 4 quadrants to the district where I live near Prospect Park. So I guess that's the southern, is that 4? Maybe 4? Maybe 4? Oh, that's north. That is northern.
Yeah.
Southern is.
Southern is 70 feet.
Okay, yeah. So born and raised in Flatbush, Prospect Park. I'm an urban planner. Went to school for urban planner, but I actually currently work at Public Health Solutions, doing government relations. So that'll be that my team. And it's my second year on the community board.
Hi, everyone. I'm Yvette Clergy. Should I share that I would share via email or not? You can take my bid.
Third test.
This is the third. I've lived in this community board for almost over 20 years now. First in East Flatbush and now in Midway. Really 2 blocks from the office if the train didn't cut me off. Yes, and so really great to be able to have this meeting in person to get to know each other. Professionally, I work in human resources at the nonprofit. What is limits? my nonprofit finances.
It's great to be able to see everyone. A little bit more.
Okay, I'm not with, Health and Human Services anymore. I'm far away I was. I'm chaired with, that, and now I'm with, I've kind of made the rounds, I think. I've been on CB14. I read that.
A legacy board member.
While, anyway, so I've kind of made the rounds with different committees at various times, and I think now I've circled back to, community and environment. So,
But can I add to that? Do you mind? Because I mean, one of the things that the board has been doing is like pairing somebody who has experience chairing a committee with somebody who's newer to that. So I sort of love like you are the mentor to a vet who's now mentoring Jarrell and that sort of turnover. Well, just sharing that, you know, and it does work with the different personalities, but I kind of,
I enjoy that.
I kind of
It's
agree.
a board. I enjoy that in our community. That's very strategic.
Are you ready to?
it's actually very, do you want to see rotating to the different, I mean, I like to come to all committee meetings because that's where I kind of keep my finger on the pulse. Because I'm in healthcare, I keep my finger on the pulse. So I'm a certified nurse midwife and women's health nurse practitioner by profession. I work at Kingsbrook, which is now part of One Group of Health, and we are the most medically underserved and at risk. We are a safety net hospital for very at risk and very large and spread out, very diverse community. Spanish and Haitian Creole are our predominant languages of the English, but we also have Arabic speakers and others. So it's Purdue. Actually, but we do have Arabic. There's a Yemeni population in that area and what else? And I'm also a professor of nursing. I'm a clinical professor. I work with lectures. I'm actually in the hospital with students. So that's
Thank you for having me. So my name is William Chambers. I'm not officially part of this community really, but do welcome the opportunity to always come out and give you presentations. And I will always be like, give my privacy to you well. I do work at Public Health Solutions as a community engagement manager for Brooklyn for the Home and Selection Network. And I do live in Canarsie. So I do attend the community here. And yes. Thank you for having me.
Hi, everyone. I'm Asma. I work at Council People Organization. I was born here. I lived here for 12 years until we moved. But yeah, I've been with COCO since 14, 15 years now. When I started off as an intern and now the chief operating officer and clinical director. And my first year.
yeah. Introduce yourself.
I went to my name is Cecile Finn. And then I live on Ocean Avenue. I went to my first community board meeting last Wednesday. I realized what have I been doing? I didn't know where this was, didn't know of it. And decided that I was gonna come this evening. I went to that one and loved it. And I'm like, I need to be a little bit more involved. So I decided to come this evening just to, get a feel of what this was. So, I'm a student recruiter at the charter school downtown Brooklyn. That's how I ended up at the community district 2. So I enjoy this.
Okay.
You. This is my fourth term
Fourth term.
as a board member. I think I joined in 2016. Basically, I'm a linguistic person. That's why I always talk about Urdu language because I started Urdu language program in this community in 2012. I arrived in this country in 2010. So next 2 years, what I observed that there is a huge communication gap between parents and kids. And the basic thing is language practice. So that's why I started Urdu language program here. And we are also working with some people for citizenship. Notes in English, we translated every question in Urdu language. And then we have a functional literacy. So everybody know about the history, their own language, and then they think about what we are doing and how we can get such results. So this is our basic and other things that we are working with so many things like Brooklyn Council, NYU, Columbia University, so many things.
I remember your program that you ran for women who had limited literacy in their own first languages, but it was a literacy program, and there were a lot of women who spoke Dari and Pashto.
Yes.
And that, and
Yes,
that was
yes,
one of the ones
yes.
I remember.
Actually,
As an NYU.
basically, this is a critical languages program. So where America, actually, this is a technical thing, where you need, actually, American government need their own language resources. So they thought those languages, critical languages, like Korean.
Yeah.
Technically, they have issues with Korean. So Korean, Chinese, Urdu, Hindi, Arabic, Turkish,
Yeah.
and so Jali. So these all, there's about 12 languages, which are basically uh, teaching in New York. That's why I'm not talking about Asian, although Asian actually, Asian and Spanish students are already learning in the schools. So these languages are not in the school of the school. So that's why these languages are critical. So American government needs their own human resources.
Those were the language, they were identified by the State Department, right?
Yes,
Yeah.
yes, yes.
I'm a certified tax practitioner, founder and executive director of American Council of Minority Women, and my community board in 2008.
Before me, I know.
Yeah. Yes. And my organization is community-based organization.
Now you need to do something else.
No, stop, don't say that. I was just telling Patricia today this story about when I first started and Doris and Jackie Bourne.
Yeah.
Were saying, I don't care, whatever else you do, just support Paza, whatever she needs. Because you are a fledgling organization, you were the first women's run
Yeah.
organization in the Pakistani American community. And now there's more. You live in
And I
what?
support a lot. Oh my God.
We don't care. Just support Paza.
And I always have very highly, I really appreciated her services because being a South Asian, actually basically we have a male dominance. So in like that environment, the male dominant, a woman is working is really excellent.
Fill the need.
Thank you everyone so much for sharing a little bit about yourselves and. That anyone would like to discuss, any suggestions come to mind about topics for future meetings?
But we will start planning the nonprofit roundtable maybe next time we meet, we'll start digging into those details.
Remind me about the reception.
What's the parties coming up this week? I'll come, I actually, everybody on the board already has this, and I only have Thursday, yeah. It's this Thursday, Community Board 14th annual reception. Don't look so. Maybe you need. Yeah. So it starts at 6 o'clock, at 6 to 9. The awards will be given out at 7. Pick up the wine to go. It's going to be fun.
Oh, wow. Can't wait. I'm looking forward to seeing everyone on Thursday at 6 o'clock at the Community Center. We turn to our meeting. Thanks,
everybody. Thank you, Patricia, for running it, getting over the.
Yes, getting our technology